Welcome to the Atrómitos Way podcast. I'm Amanda Rodgers. I'm a principal consultant at Atrómitos and a master's of public health. And we're here today to talk about missing federal data. So what do we mean by missing federal data? Why it matters for public health, for healthcare, community-based organizations, and for health democracy. And I'm here with Katy Rodgers, who's also a master's in public health. She's a senior population health and quality analyst at a health system in Idaho. And she has a very diverse academic background, which has led her to have a ton of hands-on work within public health in Idaho, transforming health systems, working with human trafficking and intimate partner violence education in the ERs, and supporting rural health workforces. I could just go on. But Katy is here to talk with us today about data and why it is important and what happens when data goes missing. And before I jump in fully, Katy, I want to acknowledge that we have the same last name. So
we sure do.
We sure do. So Katy and I formerly worked together at the Idaho Department of Health and Welfare. I was an evaluation specialist for the risk reduction and prevention section in the Department of Health and Welfare at the Division of Public Health. And Katy actually was one of the first people to help hire me, as she was the sexual violence prevention program manager. And we were coworkers and spent our mornings drinking coffee and talking about gender ideology and feminist theory and violence prevention. And then one day I introduced her to my brother, and the rest is history. So now she's my sister-in-law. So right. Yes. So we started as coworkers, and now we're family and forever in public health together. So I'm really excited to have Katy here today, because even when we're not working and we're at family events, we tend to bore people by talking about stuff like this. So Katy, let's talk about it. What's missing right now? Let's just start spitballing or saying all the things that we know together is missing from the data in CDC, the Health and Human Services, all across the web, where people need to access data on health.
Yeah. So super good question. And I think it provides a really good foundation to kind of paint the landscape of where we are today. So gosh, I cannot recall the exact date of the executive order, but the Trump administration had signed an executive order either at the end of January or at the beginning of February to eliminate instances of DEI in public health data. So what that resulted in is a mass removal of, just some have called it, websites from data sources and published reports from Health and Human Services websites that may allude to diversity, equity, inclusion. Under that definition, that includes things like race. It can include things like LGBTQIA identities. It includes things about disability or ability status. As we talk about this, I think it'll become very apparent very quickly how many data sources were impacted by this. Now, it's important to note that as of February 11th, there was a court order that demanded that these all be restored. So as we're talking today, the things that were taken away have actually been restored. But there's this caveat to the CDC website that talks about how they're either updating the website to be in compliance with this executive order, and this kind of teetering on, gosh, what does the future hold? So what does this look like, and what may the implications be should this data truly go missing? And I will also note too, there was a pretty remarkable response from, gosh, I don't even know what to call them, folks in the field who were really dedicated to preserving this history, to preserving the data sets that exist. And so even if those data sets go missing from the CDC, there are huge backups that exist on the internet that are freely accessible to folks, which is great. And again, one of the things that we'll probably talk about is what though happens when that data is not collected anymore.
Right.
So that's what I'm excited to talk about, Amanda. And yeah, we can, I think, get into it. What did I miss?
I mean, just as far as I've noted, you've done a really great job of really outlining a lot of the things that were taken away because of that executive order and are now kind of like shiftily restored, right? So documents have shifted around. So maybe they haven't been deleted, but they're really difficult to find. There's also just gaps in women's health reproductive health information, social determinants of health, geographic breakdowns, like particularly rural data. And I know that we've talked about how the Youth Risk Behavior Survey, the behavioral risk factor and surveillance system, which are two of the largest systems that look at factors that affect everyone 18 and over, or everyone, it's about 13, like ages like middle school to high school, and all of the different factors that play into their health. Just every factor, right? It goes everything from did you eat a vegetable to have you been sexually assaulted? And so that whole range of data is now at risk, and it is what informs essentially every public health program across the board. So it's just, the implications are huge, right? So I just jumping straight into what that means with the impact on public health and evaluation. So how does that affect program evaluation or equity measurement, like making sure that we're actually addressing the need in a community?
Right. Well, I think to frame that up, let's actually look at what's on the CDC website, because I think this statement really illuminates so much of the incongruency between how to practice good public health, good sound public health that we have data to inform, and what the current administration is painting as its priorities. So this was on the CDC website, actually on their HIV data page, which was one of the pages that was targeted to completely be removed. So it says, per court order, HHS, Health and Human Services, is required to restore this website as of 11:59 p.m. Eastern Time on February 11th, 2025. Any information on this page promoting gender ideology is extremely inaccurate and disconnected from the immutable biological reality that there are two sexes, male and female. The Trump administration rejects gender ideology and condemns the harms it causes to children by promoting their chemical and surgical mutilation, and to women by depriving them of their dignity, safety, well-being, and opportunities. This page does not reflect biological reality, and therefore the administration and this department rejects it. So that's a really powerful statement. When we think about the aim of public health is to improve the health and safety for all people, regardless of their identity, regardless of their socioeconomic status, regardless of their race, their gender identity, I think I already said that, or sexual orientation. So immediately we're at odds as a field with the ideology that this administration is approaching public health with. And unfortunately, the underpinnings of our field require federal funding, federal data sets to inform our work. There are too many people. So in order to surveil what is happening with health concerns and health outcomes, there are massive, massive undertakings to collect that data, right? Whether that's telephonic or electronic. And in doing that, it's just not possible for an institution that doesn't have a national reach, and even those that do, to collect data that's really sound. It is at odds, like I said, with the underpinnings of the goals of public health, and has pretty catastrophic impacts, especially when you look at health, either chronic disease or any sort of health topic where there are significant disparities by socioeconomic status, by gender identity. It essentially says that not only do those not exist, but if they do exist, it's not biologically correct, which is really harmful to a lot of those people. So what do you think, Amanda?
Oh my gosh. I mean, I'm just spinning through all of the data that I've had to comb for different projects and programs that I've worked for within the state of Idaho even, or within the academic research that I did prior to coming into working for the state. You know, we know that the majority of sexual assault cases happen to women. And we know that the majority within the lifespan of a woman, it's more likely to happen before age 18. Those are two things right there that we no longer are if these data sets are affected, like how are we going to continue to track that? Equally, we also know that the LGBTQ plus community is more directly targeted by big tobacco, and they're more likely to be susceptible to the harmful effects of tobacco. So the only way we know that is through the data, and the only way we know that is by asking people how they identify across various demographic regions and different aspects of their life. We need to know their age, their sexual orientation, which tells us more socially and culturally what they're doing than anything, and potentially also puts them at higher risk. HIV populations working more with the people who are more likely to be affected. So it creates a scenario in which we're not effectively providing funds to the things that need the funding, right? So if we are collecting data
Right.
so that we can most effectively target and help where it's needed, we're being more efficient with funding that is being received. And in fact, it creates a much more efficient program to know exactly where we need the help. So we're not just running around trying to hit every, whack-a-mole basically without knowing that there's actually a place where it needs help more. And also, it's very interesting what this implies for grant competitiveness and how grants are going to be applied for, because federal grants, as you mentioned, they run everything. They truly are one of the largest funders and largest ways in which we are effectively addressing health outcomes in our country. And if we can't say what needs the most help and where, how are we supposed to get funders to say, yeah, clearly you have a need,
Right.
So I
Yeah.
just feel so many feelings.
As do I. I think one of the other sort of, when we think about public health, right, there's so many different parts of what public health means. And we've talked about violence experience, chronic disease, but I think another big part of it that we also need to acknowledge is the actual like health outcomes and health disparities for different groups. So, for example, I work in a health system now. So I work day in and day out with health outcomes. And one of the things that is so critically important that is informed by CDC or Health and Human Services collected data are things about mortality rates, right? So even things like maternal mortality and Black maternal mortality, which consistently has completely disparate from other races, is no longer not even going to be acknowledged, but no longer collected. And so what does that mean for health systems who are trying to close those gaps, who are trying to save patient lives? And yeah, you're exactly right, Amanda. This impacts our programming. It impacts how our programs are funded, the ability to get funding and prove that this is in fact a disparity or help us target our efforts. It has some pretty major ripples through our work.
Yes. And I feel like this kind of, unless you want to comment more on that, I feel like it kind of segues
No, you go ahead.
into this next thing we want to talk about, which is the public implications of what it means when data is not being made completely public and transparent. So what that does with civic engagement and power, and where that puts our government in a sense of power. So we're currently in an administration where we have a new director who, for example, has his own set of, I'm going to call them beliefs around vaccinations. So when we have missing data, and we're just going to say theoretically, if we have missing data, then we have missing accountability. And so that means that the government and whoever is in the seat of power can say what they want to say and not go unchallenged. It creates a system where the public cannot inform themselves. They cannot go and learn for themselves to challenge what they're being told. And it makes it so disinformation and ignorance can spread more easily.
Yeah, I think, gosh, I hate that all roads lead back to the COVID pandemic, which we are still in, by the way. But the beginnings of the COVID pandemic, right? So 2020, 2021, really the years where we were looking at government shutdowns, looking at some major public health efforts, and trying to organize around that. And I think it just illuminated so many cracks in the public health field, one of which that continues to stick with me and that I personally believe has really contributed to where we are today, in that we've done a really poor job as a field describing how the scientific method impacts our work and how the science allows us to demonstrate correlation and potentially causation, but only through significance, right? And so to your point, Amanda, by the data going missing without a fundamental understanding of how the importance of data to help paint a story and how that data may shift, right? And different methodologies impact the data that we collect and the data that we interpret and publish. Without that understanding, it is really easy to manipulate whatever outcomes you want, right? We see this all the time. In fact, with the characteristic autism study that was later retracted because of those very reasons, right? Linking autism to vaccines has been debunked many times over. That I believe that doctor lost their medical license. And there have been far more studies with huge sample sizes that show that vaccines do not cause autism. But because we haven't been able to clearly articulate why that may be and how two studies can exist with different outcomes in a tweet-sized way that can pack in a soundbite, I don't know how to get there. But I know that making data sets disappear is not getting us any closer. So that's one of the biggest concerns. I mean, I have a lot of concerns about this expunging our data, but I think the ability to come back with really solid evidence-based responses for why something may not be related or how it could be related, but maybe there are stronger indicators, is one of my biggest concerns. But it also, like, in addition to erasing entire groups of people and their experience.
Right. Going back to the comment you made about maternal health and maternal mortality and women of color and Black women having poor outcomes. If we don't have that data, and we basically are saying that this problem doesn't exist, and it makes it, since there is a push more towards essentially erasure of differences within cultures, socioeconomic background, race. We're just saying, like, no, there is no difference. There are no problems here. And it's a way for a white supremacist system, an inherently institutional racist system, to continue racism by saying it doesn't exist and saying that differences don't exist. So, yeah.
That's exactly right. Yeah, I just calling on the sexual violence experience, right? We know that people who are transgender experience violence at rates, gosh, I can't remember the exact statistics, but it's
Trans
many
women are
times more than people who are.
Top violence, top homicide rates, trans women and women who are sex workers.
Yes, exactly. Yeah. And, it's interesting because there's this fine balance where I feel like in public health, our goal is to build a net wide enough to make sure that we're capturing everybody. And I think what's really important about that is that having those segmentations of understanding what those factors are really important to help us understand how big that net has to be or where we need to put that net. And, I think we see this with abortion too, right? So there are all these laws passed that limit abortion. Well, gosh, abortion doesn't just stop happening. People start going to different states or it gets pushed underground. And that's my fear, is the erasure of these experiences isn't actually going to stop them from happening. It's just going to make chronic disease rates even higher. It's going to make health outcomes even worse and make it so that people who are most impacted, most vulnerable to these different issues will no longer have any. They already don't have enough resources, but now it's going to make it so they will have very few, if any. And that's certainly not a world that I want to live in.
Right.
If I have a choice.
Right. Today, I've been really thinking about this statistic that came up in my master's program, which, by the way, was a while ago. I won't say that, but so this statistic is maybe over 10 years old or 10-ish years old. So, but when I was in my master's program, one of the things I was in a maternal and child health track and concentration. And the stat was that around 50% of all pregnancies were unintended. And unintended pregnancies led to an extremely high rate of babies that were born underweight and having more conditions or issues with being born because they are from a situation where either the mother was unable to prepare, was not in a socioeconomic status to really take care of herself very well, was basically in a situation to not be fully prepared to carry a baby. And that's not at all a judgment on the mother. That is just the conditions in which the pregnancy occurred. And when that happens, those babies have we're talking over 75% are more likely to have chronic conditions like asthma, like diabetes, gosh, can't even think of all the things. It's just like basically like every chronic condition in the list is those unintended pregnancies, low weight birth, or other complications at birth. Babies are more likely to have all of those issues, which we could also correlate back to the adverse childhood experiences, similar things there. But basically we know from data, from maternal data, from child data, from women's health data that happens. And so clearly we want to say, okay, where do we go from here? And so where do we go from here is that we help women become mothers in a way that they are ready to. And we've now created a culture where that's not even a possibility. Maybe they're not getting the education. And, we're going a little too down the tracks off of the data train, but it's the data that helps inform the programming, right? How do you know where you want to stick all of your emphasis and your forces if you had no idea that, like, oh my gosh, we have so many adults that have asthma? What is that about? Oh my gosh, so many of them were born in conditions in which their mom wasn't actually prepared to be a mom when they got pregnant. And it just changed the entire trajectory of their life. Not to say, we're not going to go too far down that road, but
No, I think going back to the data though, you're exactly right. The data helps inform the programming around it. And one of the things, again, I guess going back to how difficult it is for public health practitioners to explain the scientific method, part of that is sometimes we don't see changes in data trends for potentially generations. Right. So, Amanda, if I recall looking at that data set, one of the other factors that is generations is the likelihood to have a child at a young age. So we see this with really young mothers, right? And if with the help of those public health programmings to help build up supports for mothers and families, however those may look, it takes time to understand if that's actually impacting and reducing the rate of adolescent fertility down the line. And we saw the same thing with sexual violence prevention, right? Like, gosh, I think we used to always say, like, did anybody really not rape someone because they saw a billboard? No. But because they saw a billboard to say rape is bad, like, no, that's not really an effective way to prevent someone from raping another person. But if we work with adolescents to encourage pro-social behaviors, to encourage a strong sense of self, to understand power dynamics that absolutely impact sexual violence perpetration, perhaps we'll see lower rates. And if we can reach a broad audience to do that, perhaps we'll actually start to see that go down, but it's going to take some time.
Right.
And that's another concern that I have with this is it is so interesting to me that an administration that theoretically only will be here for 4 years can completely stop that data collection so that we're in the dark for 4 years. So we can't understand what those trends are. And perhaps the next administration will restore some version of this or the same exact version and just bring everything back. Who knows what the future holds? But we're still going to have a gap of understanding what happened, which is actually also, like, from a total data nerd perspective, would actually be really interesting to know, right? With all these other social programs getting cut, what is going to happen? Who knows? We don't have data on it. It's not being collected. But like, even retrospectively, 10 years from now, are we really going to be able to look back and see what the trends are from what happened?
Right. And I think that, like, completely goes into the next thing, because you brought up an amazing point of it being like, if we have this just like black box, this like hole of 4 years, that it's like, this is only supposed to be 4 years, and you're making decisions that are completely altering the trajectory of our future for a long time. Like, what does that mean for training the future, training the next generation of public health workforce, but also doctors, nurses, like leaders in the health field? They're our future. And so if we have people who are going through their education right now and doing workforce development right now, what are they learning when we have entire gaps in data that's missing, and this complete disconnect? And you have a lot of experience with doing training for providers?
Yeah. So I have experience both with training providers, but also as an assistant professor for public health programs. We often send our students to so in the public health program, we'll send students to national data sets and say, gosh, this is great because the sample size is huge, which means that it's a really reliable data set. Methodology is really clearly pictured and you can look and kind of pick it apart and poke holes in it if you want to. So they're a great resource for training in real time, allowing students to play around with statistics, to play around with correlation versus causation and significance between different factors. And if those data sets just disappear, where will we point them to? It's, like I mentioned earlier, thank goodness there are these repositories that exist as backups, but it's not current data, which, like, we also know that the CDC and Health and Human Services doesn't often have current data anyways, right? It takes years often to scrub data and publish it.
Yeah.
So we're not just talking this year, it's like the last 2 years of data, the last 3 years, depending on where their data collection cycle is. So I think that's a really important part. And yeah, absolutely, for the future health workforce, whether it's physicians in training or nurse practitioners, they all rely on either federal data directly from it as a direct source, as a primary source rather, or maybe they're looking at some article that has relied on federal data as a primary source. It is, even if you're looking at health outcome data from a health system, right? So you're going into your own health system, you're looking at your patient population, trying to understand trends. That's what I do day in and day out now. It is, you have to compare it to national data. Otherwise, you don't have a benchmark. You don't know how you're performing in comparison to other health systems. You don't know if there's some interesting trend that exists in your health system compared to others. And especially if you are a small health system that doesn't have access to any other people. So I'm part of a health system that's like part of a conglomerate. So I actually do have data that allows me to compare throughout the nation. But if you are a standalone health system and all you have is your patient demographic data and your patient health outcome data, it's really, really limited without any information outside of that. And so it's hard, not just for the current health workforce, but absolutely the future health workforce. I think it will impair the ability to think critically about how things are related, certainly about how to make arguments that can help advance the public health mission. It's pretty concerning.
Luckily, things have been restored, but I think the fact of the matter that it could be done so quickly and so without any warning, it indicates that it's possible that this will be a continued challenge and could be something that we're up against into the future. I think, like, I wanted to bring up this project that you and I worked on together specifically because a lot of times when this was happening, I thought it would have made everything we did, like, you couldn't do what we did now with what was happening with the missing data. So you were the sexual violence prevention program manager for the state of Idaho, and I was the evaluator working with you for the state. And you had your, upcoming rape prevention education grant, the 5-year cycle coming. And so you launched a massive strategic plan and we created a massive evaluation plan. And I don't know if you want to like jump in and just talk about all of the moving pieces that were part of that.
Yeah. I guess before I start in with this, I want to acknowledge that program has completely been dissolved at the CDC. So even this would be a non-starter where we are right now because that no longer exists. Nobody is there to staff that work. But yes, so let me talk a little bit about the rape prevention education grant. So the purpose of that grant is to prevent violence before it starts, right? So it really focuses, right? When you think about public health, you talk about primary, secondary, tertiary prevention, very much focused in living in the primary prevention of sexual violence experience. Well, gosh, like I said before, how many people do you know? Hopefully, I mean, we probably all know one, but sorry, that's my rape prevention education hat coming on. How many people do you know that actually prevented perpetrating violence from looking at a billboard sign, right? These really historically pertinent or present ways to talk about public health. Let's put some public social media campaigns out there.
Side of a bus.
Very few, if any. Right. So many things have their place, but gosh, probably not in rape prevention. So then what does prevent rape? Well, data has shown us these correlations between these social factors, right? So things like high adverse childhood experience scores, things like low socioeconomic status can impact that. Although sexual violence transcends all those things, there are certain populations that are not only more likely to experience violence in their lifetime, but also certain populations or behaviors that may indicate a higher level of perpetration. And so when we think about how to target those, it becomes a really complex program, actually, that has a lot of brocading over different chronic diseases, over different social aspects, over different occupational aspects. And it requires a really, really comprehensive response, actually, which is both really fun, but also super challenging because you have to paint the picture of why this is important. Like, what does logging have to do with sexual violence prevention? Well, we know that certain industries, right, not necessarily calling out logging, but certain industries based on geographic location, based on the type of the structure of their occupational environment, based on the socioeconomic status existing outside of that industry, of folks existing outside of that occupation may lend itself to a higher perpetration or higher experience of violence. So yeah, we convened, gosh, I want to say it was like 30 different stakeholders, Amanda, like across all different nonprofits, different organizations, corporations, different public health programs. We got them in a room and literally with sticky notes, had them kind of identify after painting this picture, which I, however long that was ago, probably could articulate much better than I just did about why it matters. We're able to identify, I think it was 5 priorities using a CDC technical package that was released that helped frame this up called the Stop SV technical package. And through that, we were able to whittle down this huge complex social problem to what are we going to focus on as a group of 30 and our networks around us over the next 5 years. And more than that, what are we going to do to measure its impact? Recognizing that changing huge societal factors takes a long time, but also there may be some data indicators where we can see really fast change. So we actually partnered really closely with the Idaho State Police Statistical Analysis Center, who helped create this incredible indicator database.
That still
Gosh, I
exists.
don't even remember how
Yeah.
many indicators. Perhaps you do. It's
Oh,
so
God.
cool. It's
Yeah.
so cool. That was such a
Well,
cool part of our
and
job.
we partnered with them, but we also
Yeah, go ahead.
I was going to say, but we also created a data evaluation team that included people from various state agencies
Yes,
and beyond the Idaho State Police. And we
that's
had an
right.
entire team of Boise State University students who were in an evaluation course that
Right.
helped us. So we literally everything we're talking about here, we're talking about the data, we're talking about the workforce, we're
Mhm.
talking about training the workforce. So we were pulling in students and we're like, this is real
Okay.
data. Help us comb through it and find what indicators and what measures are going to help explain to us whether or not we did the work that we wanted to. And it wasn't a massive undertaking. We
Yep.
all were crammed in a room for a day. It's like, you look through this data set, you look through this data set, you look through these indicators. It was, it was yeah, you're right. It was one of the coolest things that I've done on an actual practical, using data to implement a real program that then actually, could be rolled out.
Yep.
But everything in it, all the trappings of it, because it acknowledges race, because it acknowledges sex and gender, because it acknowledges sexual orientation, because it acknowledges socioeconomic status and social determinants of health. It had to incorporate all of that in order to acknowledge that the factors of where people live and how they make their money and who they're interacting with day to day influences whether or not they're going to experience violence. And we couldn't do that anymore. So anyways, all that to say that there are so many levels that are affected by this. We were in a project that was able to combine not only data but workforce development. It was a multi-fold project of both us working on programming and grant writing, working with the federal government on grants, and we were helping with the interconnectedness of the agencies in our state, training the future essentially. So I just feel like the web and the ripples of missing data Like we did something great that helps create a foundation for a project to live beyond both of our times in those positions, and a program for the state, and which unfortunately, as you mentioned, is now in a state of dissolve. But it was working with all of the facets that would best uphold a program in better conditions. So
Yep.
well, I think though, as far as just discussing where we go from here, right? Because as I mentioned, data was reinstated. We're not guaranteed, we're being shown that we're not guaranteed to have this kind of structure in place, with the potential that an executive order can wipe out anything that we need access to. So do you know, or can we talk about, like, what is it that people are doing with this threat of losing access to this? Is there local data or data collaboratives? I would love to hear more. You made a comment about a collaborative or people who have come together to basically store data where they could, or just ways in which this is being supplemented, or people are working to either help work around this issue or help as best as they can to create like a patchwork.
Man, that is such a good question. Yeah. So I am on Reddit. And so that's where I've seen sort of the like vigilantism of setting up these backups to preserve what currently exists, and the links to those, which is absolutely fabulous and very critical, and just a really cool thing that people have done in response to this. You know, I think earlier when we were talking, I spoke about just how critical it is to have a national program conduct surveillance. And it's really unprecedented, right? How is it possible? So I think there's a couple things here. So, okay, if the nation isn't going to do it, then our universities, well, gosh, probably not without federal funding. And so I just think there are so many challenges to where do we go from here? I don't know. I do know that and appreciate that there have been, you know, there's this court order that said all websites and data sets must be restored. So that is, I'm hopeful about that. I think it's a good use, a good display of the balance of powers that I hope will continue. With that said, I have some pretty deep concerns over the fact that data is not currently being collected. There's just not the workforce. So for the systems that we have set up today, which are that Health and Human Services does national surveillance, there are many teams that don't exist anymore. I think there was a 20% workforce reduction, 15 to 20%. It's not being done. It's not being planned for. You know, Amanda, you and I are both from a small rural state, and I think that there's a lot of power in understanding what is happening on an individual level. And when I say that, what I really mean is a local level. So I think even though the surveillance nationally has stopped, and there will likely be a gap in time when there just is a black hole of data, which is really, really unfortunate. I think local efforts, which is at the end of the day what public health is about, right? We're about serving the public. And when we think about who the public are, it's why we have such catered programming to the communities in which we live and work. And so I think that there's still a lot of power there. You know, I'm an anthropologist by training, and so we may not have the quantitative data, but we will never, ever lose the qualitative data, which are the stories that people tell about how they're doing and how they're being impacted by things. And so I think that there's a real opportunity to continue to lean into what those stories are, and to make sure that we're leveraging every channel that we can to talk about those stories, both good and bad or neutral. And to my former colleagues in the state and federal public health workforces that are being so impacted by this, I think it's really important to, one of the messages that I've been thinking about is, I don't know if they need to fix this right now. Where I would be shifting if I was in their role, and as someone who's outside of the system, is gratitude for them staying in there, and to like, please stay in there, because the other thing that we're facing is with a mass exodus of people leaving, we're losing so much institutional knowledge that as we do rebuild the systems, there's not going to be enough people that understand what existed before to rebuild it in a way that's really meaningful, right? A lot of effort, a lot of time, a lot of resources went into building these really comprehensive systems that have now been destroyed. So hang in there if you can, folks that are in the workforce. And I think outside of the workforce, we need to continue to make sure that those stories are heard, both of the public health workforce, but also of the public health outcomes. What do you think, Amanda?
Yeah, no, the hang in there part, man, that's like such a hard thing to root for. And also, you're like, we need people that care, and we need people that are willing to advocate. And we need, what, as far as like what needs to change, like we need federal level policy, restoring equity, right? We need to actually see equity, meaning equity variables. And I know equity is now considered a bad word in this administration, but it truly just means understanding where there are differences. And then, as we talked about, being able to target the area that needs the most help. Like, if you're in a boat and there's a hole in the boat, don't you want to find the hole? Why would you just be, going about acting as if there's not a larger problem that's sinking the ship, right? And honestly, we as community and as a nation, we need everyone to be well. We need everyone to be well in order for us to actually thrive. And we need to increase transparency around data and how it's put on there and put out on the internet or put into data systems or given access. And I really like what you talked about with the community data and just hoping that we can find ways to put more support into that and find ways to continue to hold that up. As you mentioned, it will be hard for really truly understanding impact if we don't have national data alongside our community and our state data. But it will, to continue on a community and state level, will be the one way we can kind of work through this and then have collaboratives later, retrospective collaboratives later.
Yeah. It's going to be a really interesting time. I think, public health as a field was already having some pretty deep reckonings with, gosh, how did we get here where people don't trust? At the end of the day, we see it as catastrophic because we care about data, but my goodness, there's a huge faction of the population that doesn't trust the data, right? And that's what we're seeing. And so I think it extends beyond policy and it goes to like ideology. Like, how do we get back to the fundamentals of talking about what is data? What is science? What is like, and I don't know. I mean, I wrestle with this all the time in navigating these discussions with people like that don't believe in it. And so, yeah, like absolutely well, I'll also say like, I don't think that the reason why everything has been restored, right, by a court is because it was unconstitutional. So like, yes, there should probably be some policy changes, but like also it's unconstitutional. Like policy safeguards would be great. I think on a broader scale, this ideological quandary that we're in now of like, how do we make people care about outcomes that are scientifically sound, and the importance of having these large data sets, the importance of having surveillance, the importance of having an ability to segment your population to understand how things are impacting them. I don't know how to change that on a national level. I'm struggling to change that on an individual level with certain people in my life.
I was going to say, and also you and I live in a state that doesn't, like, we've already had practice on this. Like, yeah, this is happening on a national level now, but we live in a state that is a deep red state, and we live in a state that got rid of the youth risk behavior survey before all of this came down because of just the like, what is the government doing asking our youth things about their lives? So we already had practice in this. We've already had practice in this, but you're right. There is a cultural mistrust of what data has been used for and why it's being stored.
Yeah. So, I know that we're probably wrapping up this, so I hate to leave on like a dark note in that, like, I don't really know, which is true. I don't. But again, like, I'll go back to what we do know is real are stories that people tell.
Yes.
And so I think that there is, and that's true regardless of administration, regardless of geographic boundaries, regardless of political ideologies. When you look at the other countries who have endured dark holes in history where data was either not being collected consistently or at all, or there wasn't infrastructure in place to do that. And we look back on what was going on from a public health perspective of those countries. It was either other countries conducting surveillance on how things were going, or stories of how things were going and then what happened from there. And so I think there's a lot of power in that I believe is, you know, going to be helpful. It's some point. Now it's helpful now, but yeah, I don't know about this black hole that's currently
Right.
exists.
Right. No, I think that that is a really great point, Katie, that data is, in many ways, data is just storytelling, and collecting data is storytelling. And there are ways for communities to do storytelling in data collection through various different ways. And so it will be a matter of how maybe like professions join forces, that there be ways that on a more grassroots level, professionals within the field can create collaboratives and networks that work for better data access and create something of integrity within itself. And it will be something that, hopefully without everything completely falling apart, we can repair together. And it will take action, and it will take action from people who care and stick in it, like you said, who stay with it. Right.
Yeah. Without having to be a martyr, right? We don't want people to like have adverse health outcomes by
Right.
staying in a toxic job. That's not my point. I guess my thing is like, if there's a way to hang back a little bit and not feel like you have the world resting on your shoulder, lean into that there are public health people outside of those toxic work environments who can like maybe step up and help lead and support you so that you're not having to live in that, you're not having to like constantly reckon with like what is happening and these resources just disappearing. You can spend more hours focusing on, for example, the 5 things you did last week, while we work with programs and associations like the APHA and local state public health associations to really organize around what does it mean to be a public health workforce that's coalescing around what is happening.
Yeah. Yeah, no, I agree. I think public health is at a reckoning point. And I think across the board, being in public health and
Yeah.
having a public health background, having colleagues and friends who are in public health across the US, everyone I know is in this point of reckoning. And I think that all of us recognize that there's just a shift that needs to happen. And maybe this is counter to how we were trained and everything that all of our values and core principles that we signed up for. But many people in public health signed up to do it because they care about their communities. And so I think as long as community care is there, like a way will be found. So yeah. Well, Katy, I just really appreciate you coming on and talking with me. It's such an honor to have you here with me because, as I mentioned earlier, we end up in our little corner at the family dinner table talking about things that that maybe the rest of the family doesn't want to hear.
Really fun.
Yeah, and you are truly one of the most intelligent people that I know and most driven people I know. So I just
Likewise.
love being able to have a platform where you can speak all of your deep knowledge as well.
Thank you for the opportunity and for bringing up this really important topic in this very odd point in time. I really, really appreciate talking with you too, Amanda, whether it's at the dinner table or on a podcast. Who knew? Very cool.
Yes, thank you.